In just 20 minutes, I hope, I'm going to introduce to you IHMS as an organization, provide an overview for you in terms of what we do within immigration detention and our wonderful nurses and doctors and allied health professionals who deliver the healthcare, describe the key principles of the IHMS approach to medication management, examine self-agency as a method of medication administration within detention, and explore the risks and issues encountered and the associated strategies and solutions being considered moving forward. IHMS, for short, is a private medical services company contracted directly by the Department of Immigration and Border Protection and has been so since 2003. We're contracted to provide healthcare services to a standard equivalent to the Australian community standards. Governance of the service is maintained through quality standards specifically prepared by the Royal Australian College of GPs. To ensure we meet these standards, there is a robust quality system in place, audited both internally and externally through various forums within the department, but also independently through committees such as the Independent Health Advisory Panel. Over the years, IHMS has evolved and diversified tremendously based on the patient population entering detention, their origin, and the specific healthcare needs. We provide a multidisciplinary approach to healthcare. However, we are contracted as a nurse-led service, with nursing staff making up the majority of the workforce. Certain services which are standard at each of our clinics, and there are certain services at each of our clinics, and these include, but are not limited to, health screening upon arrival, ongoing health promotion campaigns, detection, notification, and management of communicable disease, public health consulting and advice, prevention of infectious disease outbreaks, access to prenatal and follow-up care, mental health screening and ongoing mental health services as required, women and men's health, coordination of services for those in community detention. So it's quite a broad range of services we provide. There's also additional services we provide offshore in both Manus and Nauru, which are focused mainly on the capacity to provide resuscitation and stabilization for our patients given their remote location. We organize medical evacuations for them and their transfers to an upgraded center of care, a robust vector control program, as well as ensuring appropriate resettlement of refugees into the communities within Nauru and Manus. This map illustrates the locations of our clinics currently, from Christmas Island in the west across to Nauru on the east. Following a change in policy and legislation and a corresponding decrease in population numbers, we now have 8 sites onshore and 2 offshore. So we've decreased down from 25 sites in 2012. At each facility, we have a health services manager, who is usually our senior nursing manager, managing our clinics. We have both primary mental health team leaders, a primary healthcare team consisting of nurses, doctors, paramedics, midwives, immunization nurses, and a very robust mental health team consisting of mental health nurses, counselors, psychologists, and a visiting psychiatrist. We provide access to extended health services, including physiotherapists, dentists, allied health professionals, visiting specialists, and telehealth. The structure at each facility does vary depending on the specific patient requirements. And each site is supported by us at head office, where we also have medical directors, operations managers, a quality team, a learning and development team, myself, who provide additional governance, oversight, and support to each of the sites. These photos illustrate what some of the facilities look like, a very quick snapshot for you. They vary significantly, which I particularly found was quite a challenge in terms of trying to, adapt our clinical service across the varying facilities within the network. So the overarching philosophy of healthcare within immigration detention is to ensure patients, including those in community detention, have access to a standard broadly commensurate with that available in the Australian community. Our practice supports the Detention Health Framework of 2007 with a philosophy of empowering patients to manage their own healthcare, including their medications. We understand it's not possible to eliminate all risks within healthcare. However, IHMS considers risk management to involve the following: risk awareness, risk mitigation, decision-making around risk and benefit ratios, and continuous quality improvement. To that end, our aim is to deliver safe and reliable service and medication administration practice, which is regularly reviewed and amended in accordance with accepted industry practice. To align the philosophy of empowering patients and community standards, and where safe to do so, we have designed a service delivery model which encourages patients to take joint responsibility for their healthcare. It allows them to store and manage their own medications and ensures compliance with agreed treatment plans. What are the benefits of self-administration? So in addition to the accepted benefits within the Australian community, we within IHMS have seen that self-administration helps to empower patients to take responsibility for their own healthcare and manage their own medications, enables them to take greater proficiency with regards to management of their medications, particularly with respect to discharge planning, significantly reduces the requirement for nursing staff time to dispense medications, reduces level of anxiety and aggression because patients are better able to manage their own pain levels and therefore generally don't tend to experience pain levels to the same extent. Reduced waiting times and queues for medications as they're not required to attend clinics on such a frequent basis, and reducing breaches of privacy and confidentiality. So in terms of introducing the concept of compliance aids for medication management, this occurred in March 2014 for us in conjunction with retendering for the onshore contract as the incumbent healthcare provider. A key concept of this tender for us was to empower patients and promote self-agency. This was at a time when across the network there was a consistent arrival of illegal maritime arrivals, or IMAs. These are boat people, or people who've arrived by boat to Australia, who presented with a very specific disease profile, and for whom discharge planning for us was a very key component. Within our tendered service delivery model, we calculated that 56% of the patients would be prescribed medication at any one point in time. This was based on the stats and the data that we received in the reference pack back in March 2014. Approximately 7% of patients would be prescribed restricted Schedule 4 or controlled Schedule 8 meds, and therefore would be required to have those directly administered by nurses. Previously, the model that we had allowed coverage across extended hours with some more remote sites such as Curtin, Leonora, and Weipa adopting a 24-hour coverage model. With the closure of most of the remote sites across the network, IHMS proposed to align the staffing model to community standards based on a 9-to-5 weekday model. The 7% trigger for those requiring directly nurse administration was discussed with the department, and we agreed to increase that to 14%. So we doubled that to allow some flexibility in the proposed self-agency model to manage the increased requirements in directly administered medication on an intermittent basis. So this 14% trigger is called your medication complexity. The staffing model was set accordingly across each of the sites based on the population size. In terms of the proposed model, all patients requiring medications would therefore undergo an individual risk assessment called a self-administration of medication risk assessment. So we call that SAMRA for short, and you can see why. They're completed by the GPs at each of the sites and at the time of arrival into detention. Ongoing assessments are completed based on clinical indication, but at a very minimum every 6 months. The GP makes an assessment of whether the patient is able to self-administer based on their ongoing requirements and provides an outline of the support and supervision required to facilitate this. If SAMRA approved, the GP then prescribes up to a week's supply of medications in a blister pack and will specify which can and can't go into that blister pack as well. Behavioral histories are obviously assessed very, very carefully. Restricted and controlled medications do not go into the blister packs, and there's special considerations for patients such as those with hepatitis on interferon, or people who are on DOT therapy for tuberculosis where they can't go into the blister packs. And we're also guided by the local pharmacy as well in terms of anything around, effervescent tablets or heat-sensitive, light-sensitive tablets that can't go into blister packs. The decision is then discussed with the local security provider, which is Serco, in the onshore environment, to get a full understanding of the risks and obstacles to implement self-agency. We have daily and weekly meetings around medication management to look at the operational, tactical, and strategic levels of the process. So following some robust research that we carried out, it was evident that there was not really a tool available readily for us in terms of something that was going to provide a clinical assessment with the appropriate clinical assessment, but also be suited for the detention environment. So after various research, we decided to design our own tool and took examples from within the community. This is the first version that was released back in 2015. We're due to release a second version in the coming months, and it'll be automated within our electronic medical record system. As you can see, the form asks the GP, hopefully you may not be able to read that, but essentially the GP assesses the mental health status of the individual, knowledge of their condition and their motivation to manage their own medications, provides an assessment of any obstacles for patients in terms of whether they're literate or any physical dexterity issues, and an assessment of the patient's behavior to avoid issuing blister packs to patients with a history of medication abuse or hoarding. The GP then documents whether they feel the person can self-administer, for how many days at a time, and if there are any special considerations. And here's just a quick snapshot of the roles and responsibilities at a very high level of the different providers at a local level. So you've got IHMS, who provides assessment, categorization, periodic medication reviews, ongoing education and awareness, provision and supply of medications, works collaboratively with all stakeholders, provides medication reporting on an ad hoc and also agreed rota, audits incidents and then looks to carry out remedial actions to address those, reviews medications from the local pharmacy to make sure that we're getting what we ask for in terms of the original prescription, and conducts regular reviews of prescribing practices. The Department of Immigration provides access to interpreters for us, which is very important to ensure that the patients understand what it is that they're actually needing and taking, and funding for the infrastructure across the network, of course. And the facilities and detainees provider provides infrastructure to securely lock away the medications, make sure that there's secure refrigeration for certain medications, maintains the lock boxes, carries out targeted room searches to make sure that people are not hoarding or exchanging medications, and also looks out for behavioral issues as well. So IHMS has responded proactively and appropriately to the issues which have arisen from using blister packs. This table illustrates some of the risks that we've, and the mitigation strategies that we have implemented. So an example of a risk could be that there could be non-compliance of regimes. That could be down to boredom, lack of understanding, feelings of frustration, anxiety of being in detention, which we see regularly. And a way of overcoming this was to ensure that we had close supervision and daily dosing for patients who were considered at high risk of self-harm or those likely to abuse or self-medicate inappropriately. Opportunistic reviews also allow us to investigate the causes of non-compliance with medication regimes. Another risk is acceptance of the new approach. So again, a comprehensive, robust education program was rolled out, not only to the patients themselves, but to their stakeholders, to ensure that there was an initial assessment of the patient, provided an opportunistic basis in terms of providing ongoing education, and at times when we provided repeat blister packs to the patients, we could also then offer up education at that time as well. And education for the stakeholders is extremely important so that they really understood why it was we wanted to implement this new model and what we needed from them to support us and help us implement it appropriately and effectively. All of the risks are reviewed, assessed, and analyzed to ensure corrective actions required can be implemented, documented, and then inserted into either a local work instruction or into the policies and procedures manuals that we have that are generated out of head office. So we've had a quick snapshot of what the model itself looked like. Now in terms of how has the immigration population itself changed over time, and that's really important to understand. So as you can see, this graph shows the number of people in detention from 1990 to January of this year. There's a trend, consistent rise in population numbers from January 2009 to January 2013, with a consistent decline ever since, which is obviously a good thing. A change in government and associated policies, the transfer of people from Christmas Island across to Naroon Manus, and the settling of people into Australian community has led to this population decline. This table shows the number of people held in immigration detention facilities by the type of patient that they're grouped into. It sounds terrible to do that, but it's important for us to understand that there are different disease profiles that come with different patient groups. Interestingly, whilst the numbers have decreased over time, the classification of person entering detention has changed significantly. 521 people who arrived unlawfully by air or boat in held detention represented only 37% of the total population as at the 28th of February this year. 862 people, around 62% therefore, were people who arrived in Australia lawfully and were subsequently taken into immigration detention and had visa cancellations for either overstaying or breaching their visa conditions. Very quickly, this table and graph shows the total percentage of patients on regular medications every 6 months from June 2015 through to March of this year, with an increase of 8% in terms of those requiring medications. This table and graph shows the complexity rates for medication management across the onshore network between June 2015 and March of this year. So the complexity is the measurement of the patients who require directly nurse-administered medications. We set it in at 14% in March 2014. As you can see, it's around 30% and has never really dropped. And that's the result of the new cohort coming in from corrections. So the implementation of the new service model in 2015 and the significant change in cohort has had a real dramatic effect on our service delivery. To summarize again for this graph, you can see that all sites have consistently triggered, apart from Yonge Hill, actually. For a couple of quarters, they didn't trigger. Sometimes 2 to 3 times the agreed thresholds. So that's meant that we've had to, it's really diluted our ability to, I guess, manage other clinical services proactively. And it's meant that we've operated an extended weekday hours and weekend service. So the way forward, I think it's really important to summarize that there's still huge benefits of self-administration, and where possible, it's a model that we do push forward where we can. It's allowed standardization of risk assessment processes, early identification of ongoing medication requirements to individualize medication plans. Requirements for follow-ups are established early. We've seen a reduced number of incidents in actual direct nurse administration of medications, which is really interesting, and enhanced documentation because of a standardized process. More robust and collaborative stakeholder interactions, which can only be a good thing. And finally, we're working with the department at the moment in terms of having a workshop. We had a workshop at the end of last year to look at how do we now take this new model forward based on the changing cohort, and how do we adapt to the ongoing clinical requirements. All stakeholders agreed that the preferred model is still self-administration, but we need to basically manage the risk effectively and ensure that we're providing healthcare and we're empowering patients to self-administer their own medications appropriately. Sorry. So when reviewing key issues and priorities, it was agreed that the medication management model needs to be a hybrid of existing models tailored to detention. We need to clearly balance clinical and security risks. We need to consider all impacts of change on each stakeholder. The model for self-agency of medications needs to address risks between and within cohort groups, so patient groups. Consider limitations of existing infrastructure within the detention environment. And we need a more formal data collection process and analysis and interpretation of trade and trafficking of self-managed drugs, which would then possibly impact on evidence-based decision-making. So we would get that from the facilities provider. Finally, final slide. This slide illustrates the key areas identified at the workshop in relation to possible changes to self-management of medication to address the issues and risks going forward. They are the development and agreement of a joint review process that targets identification and continuous improvement of network issues in relation to the overall model, processes, and governance mechanisms. Improvement of site infrastructure, where it impacts on the effective adoption of self-management of medication. Strengthening of medication management considerations in terms of where we place our patients in the network, and that improves detainee health outcomes and helps us to manage clinical risks. Greater measurement and monitoring of risk factors in relation to self-agency of medication, ensuring evidence-based decision-making to manage risks associated with medication misuse. Improved focus on education and other mechanisms to drive patient behaviors towards self-management. To review and change the complexity trigger, which obviously wasn't correct, well, it was certainly correct with the IMA cohort, but changed significantly over time so that it better aligns with the patient groups and their requirements. And improved continuity of care of patients from corrections to detention, movement within the network, and also when we release them into the community. So I apologize, there is a lot that I've covered off there in a short 20 minutes. I will be around for the 2 days. Very, very keen to talk to you about what we do within immigration detention. It's a very, very scrutinized area of work, and certainly I'll be very happy to take any questions or address any feedback offline as need be. Thank you very much. Yeah. Yes. We did initially, when we first introduced it to the cohort, I do apologize, I'm so used to using certain terminology, but patient groups, back when we introduced the model, it was, like I said, it was very much an IMA cohort, so people arrived by boat. And that's what the model was designed to support, because these were people that we were preparing for discharge into the community. So with that group, we absolutely did see a big uptake of wanting to adhere to the actual model. As time has changed, and we've seen more and more people coming in from corrections, they're called 501s, unfortunately, but they're from corrections, we do see a lot of illicit substance abuse, a lot of hoarding, and that lack of practice. So we have to take an extra, there's a level of risk there that we have to then manage with the security provider. We'd still want to try and ensure that they adhere to the model, but we have to manage the risks as well in terms of abuse, hoarding, sharing, trafficking, that sort of behavior. But certainly it's an ongoing thing. We review it. I mean, I look at our incidents on a monthly basis. We then report up into the clinical governance framework. We then report to the department's clinical governance framework. We're scrutinized by the IHAP bodies, that sort of thing. So we're constantly reviewing the practices that we implement and deliver. I'm not sure if that answered your question. There are so many confounding factors. We have done some research, and I'm looking at the moment to get permission to publish some. As I said before, we're very heavily scrutinized, and we do produce a quarterly health data set, which is accessible to the public. I would love to be able to publish some of the statistics that we've found so far, but it is a matter of seeking approval through the Australian Border Force Department of Immigration. I'm very happy to talk offline, actually, in terms of all the trends we're seeing around medication incident management. It's, like I said earlier, we're seeing a lot of a reduction in incidents related to direct nurse administration. But it's then shifted my focus towards the other types of incidents we're seeing around medication administration, which is more around, the pharmacy supply, or the checking or the governance of the actual packs themselves, and how they're, stored, and all those sorts of things. So whilst, we've made huge improvements in one area, it's, as with everything in healthcare, it's shifted our focus towards another area. In terms of medication specific, we don't. We have very generic level information, which generally I write, and it's then translated into around 16 to 20 different languages. What we're seeing, and I've got another presentation at the end of this plenary session, which talks around where the people are coming from at the moment. And I guess, a lot of the patients now that we're looking after from New Zealand, UK actually, they're overstayers of their visas, the people coming out of corrections, that sort of thing. So whilst there isn't such an emphasis on having that material translated, we still do have people from Malaysia, Iran, Afghanistan, Iraq still within the system. So we do have general information that's translated. Medication specific, no, because there is just so much of it that we could look to produce, but we always make sure that there's interpreters available, and the Australian Border Force is responsible for providing those interpreters to us. So we wouldn't engage in a consultation with a patient if we didn't feel that they could understand what we were saying, and had an acceptance of managing their own healthcare sufficiently.
Well, thank you very much, Leanne.
Welcome.
And I know you've got another presentation.
Yeah.
So thank you very much.
Thank you. Thank you.